Good morning. It is Friday, May 8th, House Healthcare. Um, Jen has been working furiously, and thank her so much for everything. And we're gonna look at some changes. If you recall yesterday on 190, a group of stakeholders sort of got together to try to hammer out some of um, the differences in cleaning up the language. I will also say that yesterday's version of this bill contained section, I think it was 4 and 4A. And I have, that was around teachers' health benefit plan. And I've removed that from the bill and kept the reference-based pricing in there for them. And I just want to be really clear. We deeply, deeply value our educators. We balance things in this committee because we are looking at the system as a whole. And we have to be able to look at all the systems within our entire state and how they work together. I will tell you, I put that in there to start a conversation, and I am really glad that we had the conversation, but it doesn't mean that we value our teachers any less. So I just wanted to be really clear about that. And since I am the one that put it in the bill, I removed it from the bill. So, but thank you, everybody, and I hope we can continue the conversation as we look to, trying to make our healthcare system in Vermont more affordable and sustainable, and ensuring that everyone has access to high quality healthcare. Jen, are you?
Yes.
Okay.
I'm just getting on the Zoom. I just sent the language to Fashion. So the same Zoom as the center in Fashion? Yeah.
Are we not gonna discuss that issue any further because it was removed from the,
We can discuss it in terms of
like,
the reference-based pricing.
okay.
First.
Because I had a thought, I'm glad it was removed, but I had a thought about the issue, and if we have to wait till another time to talk about it, that's fine though.
I think I'd like to table the issue.
Okay.
Thank you, Bill. And thank you for your thoughts yesterday on it. We had some really good. And we learned an awful lot
Yeah.
yesterday.
Well, when the time comes, I was thinking a lot about what might be other solutions for it, so we can come back to it.
FYI for the committee, we have Jen until about 11:05. So hopefully she can walk us through the language, but so let's keep our questions for Jen contained to the language so that she can then go and we can have committee discussion.
I wonder if we could use AI to screen our questions in advance, and then it could decide if they get asked. We type it in our computer.
Didn't we make that illegal?
As long as we're not asking for clinical advice.
All right, good morning, Jen Carvey, Office of Legislative Counsel. And I think this draft is going up on the website. Tasha, if you're printing copies, can I have one too? Okay, for me. Just a minute. So this is a new draft of S-190. For the most part, I have highlighted changes. There were a few places we're trying to show you the strikeout and the new stuff was confusing. And so I got rid of some of the strikeout stuff. And in one case, just deleted a whole section. So it starts off with the reference-based pricing section. And I think the there's a couple of changes here. One is to add a version of that intent language that you looked at from the healthcare advocate yesterday. So I actually put in the beginning of the subsection on reference-based pricing and proposed adding, there's currently a subdivision A and
Refresh.
B, so subdivision E1A and B. I've put in a new B and made what was B, C. So this would now say that the board shall utilize reference-based pricing to reduce hospital prices incrementally until they are equal to national median prices by hospital type by, I think the language said 2030. So I took a guess and said calendar year 2030, since we talk a lot about fiscal and calendar years here. The board shall use the highest quality nonpartisan data demonstrating hospital prices as a percentage of Medicare. I think that's what it meant, to evaluate progress toward reducing hospital prices in Vermont to the national median. So those who were involved with or in favor of the language, I hope will let us know if we have missed something in putting it into the bill draft. Then I changed the language around provider contracts with hospitals and health insurers showing beginning to express the rates as a percentage of Medicare or another benchmark, and move that date at the request of Hospitals and Green Mountain Care Board from October 1st of 26 to January 1st of 28. Next, I have deleted section 2, but replaced it with some other stuff for you. Ask too much about that. So section 2 of the previous version had been the reference-based pricing, qualified health benefit plans and plans covering school employees. It was a session law provision because it applied to 2027 and maybe later years. Instead, I have put it into the statutory language. And so I've combined it with what had been in section 3 on hospital budgets and budget review. So we already had the definition of Medicare adjusted base rate added, but then you can see, put it in as a new section 9459 and incorporated the provisions that were being proposed as 9459 in the previous draft. So we have definitions. So I tried not to highlight things that had been defined in previous section 2 because you had looked at them at least a little bit, and just flagging the changes. So the definition of hospital, as we had seen in the version we looked at yesterday, it excluded critical access hospitals. This also excludes a hospital classified as a Medicare dependent hospital under federal regulation, or a hospital that is participating in the Rural Community Hospital Demonstration Program through the Centers for Medicare and Medicaid Services. My understanding is this really applies to Brattleboro Memorial. Currently, I think may fit both B and C, but is the only hospital that is reflected there. So that is what that is carving out. I think that is
Clarifying.
due to their financial.
So then this would only apply to the PPS hospitals?
Yes.
That's what I'm understanding. Yes.
All right, and then this would do some specific things for fiscal years 27, 28, and 29. These are hospital fiscal years, so that's starting October 1st. So in establishing fiscal year 2027 hospital budgets, this would allow the board, so it wouldn't be required, but it would allow the board to direct an amount equal to 3.5% of the hospital's combined commercial net patient revenue based on approved fiscal year 2026 hospital budgets toward reducing commercial reimbursement rates for the qualified health plans and the plans offered to school employees based on a percentage of the Medicare adjusted base rate determined by the board for each item provided and service delivered in Vermont to enrollees in these plans. And then in establishing fiscal year 28 and 29 hospital budgets, it would allow but not require the board to limit commercial reimbursement rates for those same plans by to not more than the following percentages of the Medicare adjusted base rate for each item provided and service delivered in Vermont to enrollees in these plans. For hospital fiscal year 2028, not more than 300% of the Medicare adjusted base rate, and for hospital fiscal year 2029, not more than 250% of the Medicare adjusted base rate. Then it would,
Do you have a question on language?
I did. You said combined, you used the word combined, and I just wasn't sure who was being combined.
the hospitals combined, so of those hospitals,
Hospitals combined commercial net patient revenue?
Yes.
What's that? Combined. What's being combined?
Basically,
all of their net patient, so if you take all of the hospitals who are within the definition of hospital and you add up all their commercial net patient revenue, and then you take 3.5%.
So it would be, Blue Cross, MVP, United Health. I mean, is that what we're talking about?
Believe that is their net patient, what their revenue, I mean, that's the commercial of their net patient revenue as opposed to a public payer.
That's what it means, that anyone that's not a public payer.
Yep.
Okay. Thank you.
A public payer or private payer, I mean, commercial, I believe, you'd want to hear from maybe the hospitals and the Green Mountain Care Board, how they define it, but that is a defined term in the universe of hospital budget reporting.
And they report those individual numbers to the Mountain Care Board.
The idea was to use a known quantity because a known set of data because it is based on approved fiscal year 26 budgets.
Thank you.
All right, so then it keeps language directing the carriers or registered carrier or health benefit association shall not reimburse or agree to reimburse a hospital more than the percentage of the Medicare adjusted base rate specified by the Green Mountain Care Board. Subsection B, if any, because it was permissive for the applicable hospital fiscal year, again, for items and services delivered to Vermont enrollees. And then carries over that language about what to do if there's a capitated or other non-fee-for-service reimbursement arrangement happening. And then saying that a hospital or hospital provider reimbursed in accordance with subsections B and C. So the limit or the potential for limit from the hospital side and from the payer side cannot balance bill, cannot charge or collect anything else. It does, and then I wasn't sure where the committee would be on this or where the stakeholders were on this. I kept in language saying if a hospital is required by the board's budget order to reduce its commercial reimbursement rates further than what would be achieved under subsection B, then the hospital would reduce its rates that exceed 500% of the Medicare adjusted base rate, or if they don't have any of those, the highest rates in relation to the Medicare adjusted base rate. And then leaving the ability except as provided in subsections B, C, and that previous E. A hospital may increase the commercial reimbursement rates for one or more of its service lines, such as primary care, as long as in doing so it remains compliant with the total budget ordered for the hospital by the board. And then separating out as recommended by DFR, making it clear that it's the Green Mountain Care Board doing review of premium rates for the qualified health plans in accordance with ABSA 4026, and that it is DFR that is doing the review of the rates for health plans offered to school employees by Health Benefit Association in accordance with ABSA 4026 and 24 VSA Chapter 121, Subchapter 6. I'm going to pause there or keep going.
I would say keep going unless anyone has any questions.
Sections 4 and 4A are deleted. Chair addressed those at the beginning. Those are the sections that were setting some actuarial value limitations on plans offered to school employees. Section 5 keeps the hospital outsourcing report. Section 6 keeps the exclusion of healthcare professional bargaining from reference-based pricing. Section 7 keeps the language on Green Mountain Care Board appeals. Sections 8 and 9 keep the language on data infrastructure. Section, what is now 10, it had been 11 around critical access hospitals. This one has gotten some changes. In looking at this afterward, it may make sense to take out some of the intent language, depending on where you go on this. But this would take out the language that actually requires critical access hospitals to reduce their rates. Instead, it would require critical access hospitals by September 1st to identify all outpatient services for which the amount the hospital charges equals 5 or more times the Medicare allowed amount for the service. And in new language, post prominently on its website and in outpatient departments of the hospital, information regarding the federal requirement that Medicare beneficiaries must pay 20% of the charge for outpatient services at critical access hospitals, and that Medicare beneficiaries may be able to receive care with reduced out-of-pocket costs from other providers. And then it would continue to say, to the extent the Green Mountain Care Board engages in efforts to address the issue in hospital fiscal year 27, it must consider any proposals from the critical access hospitals and other interested stakeholders and ensure its actions are consistent with hospital transformation and principles for healthcare reform. The act will take effect on passage in what is now section 11, and you may want to change the title of it.
Leslie?
So just for clarification, went by fast. BPI is not included then in the records-based pricing? Or did I miss? It's not included anywhere.
No, they are.
They are included.
Okay, so
in
just point me towards that.
So that's section 2.
That's a
No,
deleted.
section 3.
Okay,
Sorry,
thank you.
section 3. And so everywhere in B and C where we were looking at the back up. Everywhere that we were
Okay, thank you. Page
looking at
5,
the
looks like.
limitations,
Yeah.
Page 6.
page 3. Yes, page 6. So we're still keeping all those definitions, and we're still talking about rates, reducing commercial rates for qualified health plans and health plans, benefit plans offered to school employees by a health benefit association. That is statutes for BPI.
Okay. And one more question, but this isn't for Jen, but there are no other witnesses, so I just don't know where we're going with this, but I do have a question that's not for Jen.
Okay. We'll have some witnesses.
Okay.
There are maybe other sections.
Oh, I'm sorry. Go ahead.
I am concerned about the sufficiency of the notice. Page 14, bottom of the page, 14 and 15. And I was hoping for, really clear, disclosure to each person that might be having an outpatient procedure with a critical access hospital, and to post prominently on the website and, in the hallway. I'm just concerned about the sufficiency of that. And the language is a little vague, like what does this actually mean? Oh, it might cost more if you go somewhere else, well, how much more? And so I would be interested in seeing more effective notification in that section.
I would love to see all that too, but I think it would be operationally impossible. First of all, outpatient services are like all outpatient services. If you're getting a lab drawn, should you get like notification of how much it might cost you? If you're having an office visit with a doctor, I mean, every single service that's done on an outpatient. So, I mean, it would literally mean every single last thing that's done. Which I'm not sure how you would operationalize that. And the other problem is how would that individual hospital be able to determine what it might cost somewhere else when they don't know what that somewhere else is charging, or what other somewhere else? I mean, would they have to like have a listing of the charge masters and what possibly you'd be paying at every individual hospital in the state? Or
No, I mean,
like, it's like, I agree. I mean, we certainly could be a little bit more specific about the information, but I'm not sure we can be too prescriptive
Right.
Yeah, when you're
Well, it doesn't make it, so, no, not.
from a practicalities.
Yeah,
standpoint.
not to that extent, but I mean, if a patient is having some kind of interaction about a procedure, whatever it is, they're already in communication and contact with their provider. And, so to sort of generally post it somewhere that they may not see when they're actually in direct communication with them. I would think, one of the things I could imagine is, because this is a critical access hospital and you're having an outpatient procedure, you may see substantial savings if you have it in the hospital or you go to a P, the other Ps. Yeah, one of those hospitals. You might want to look into it. And then they can decide, they have enough information, to look into it and make it an informed decision. So I don't know, that's one thought. People have that.
I'm struggling with that too, because there's a sign on the wall, but where do I go? I don't, okay, I may be able to find it, but what does it mean? I have no clue. So I'm struggling with like, who's in charge of that problem? And what I'm wondering is, should we direct them to Voz as someone who has oversight of the entire system to help direct people? I know you're gonna hate it. She gave me the face, I got the face. But who's in charge? It's sort of like, who's in charge of the problem? And I'm trying to figure that out. And
Just put Devin's cell number. in.
Yeah, there you go. I know the right person for you. So I'm just wondering that we need to help people. We can make a sign, but I would read the sign and say, now what? I don't know where to go. Who's going to help me discern the best place for me to get this?
And it's a very narrow category. It's outpatient critical access. It's not everybody.
Well, I mean,
That is actually not a narrow category. That is
It's
the
every-
broadest
yeah,
category.
it's every outpatient procedure, but
It's not just outpatient procedure. It's every single thing in a hospital that's done on an outpatient visit. That's, if your primary care doctor is at is a critical access employed, that would be, that office visit, that blood draw,
Yeah.
that, removal of cerumen impaction. I mean.
That's earwax for anyone that. It's one of my favorite things.
I love when they do that.
Yeah, it's so good. It's so successful. So, I agree that this is worse than doing, it's confusing. Is it worse than, I'm just trying to think of a person who is there getting
For
there.
more information, please call Patient Financial Services.
Absolutely.
There you go. I was gonna say something like that.
But that means financial, they need to know. They'll have to have me informed.
No, I'm sorry.
Yeah, go ahead.
There has to be like. Calm down. We can direct them. And there's some onus on people to be able to know where to go as well. So like if we say, contact patient financial services, if you're getting care, you're gonna know that there's a patient financial services, right? Like I don't think we
I
need
hope
to
so.
be more.
I'm fine with contact patient financial services. I think that's the right thing. So thank you for that. It's just, I think they need a place to go.
You're off the
And so
hook.
So we have to train everybody, so you still get.
And I think we'll be getting more actual information on these categories. And so we'll have more data, like which particular procedures are really impacting people.
I will say, and I'm sure that Devin can testify to this and I will say that Voz did receive information from CMS regarding this issue yesterday. And there are limitations on what we as a state can do on this issue.
Is that something we can hear about or not?
That's,
Okay, I'd be curious.
Yeah.
But disclosing to patients so they have informed consent, hopefully it's not one of those things we're prohibited from doing.
correct.
We're not, we're.
We're not prohibited from doing that.
That's all we're talking about right now.
Is there, can we have in here that hospitals shall develop the communication and the board approve like in development, I mean, I know often sometimes we do things and then DFR will sort of approve it. I don't know how to write that, obviously, but that, you know,
So you want them to, for the, what they're posting in places? Okay.
Yeah.
Yes.
and then have it by board approval.
Same way we did with, how to get patient,
Patient financial.
financial assistance. It's the same process. That's what I'm thinking.
That work for everybody?
Does it include Leslie's suggestion about a real?
Yeah, there would be a real contact. Yeah.
That's better.
I'm sure the board will ensure that it is comprehensive notification in a manner. Okay. Any other questions on language at all?
I have just been freed,
Oh,
so I'm not going to.
you aren't. I was hoping that, and I'll have people come up and speak to this latest version, but we have bumped the healthcare advocate multiple times. And I promised him, he got 5 minutes yesterday, just on the tail end of it. But, I'd like him to come up first and testify on this bill, because I don't think you have, other than your few minutes. You've been upset that you keep getting bumped, and now all of a sudden you don't know what you're gonna say.
Because we fixed everything.
It was a very effective 5 minutes you had this.
Thank you, Jen.
Yeah.
Thanks, Jim.
Great work. And your proposed language.
Oh, miss response.
Thank you, Mike Fisher, healthcare advocate. Yes, I actually do think that in my very brief 5 minutes, it was actually efficient. So that was significantly what I wanted to say. I guess, but I'll just go to big picture for a second. Boy, this is the time of year where we all have to do deep breath. Nothing is perfect. There are many things in this that I might draw your attention to and suggest changes that are not appropriate to do at this time, given the timing. But I think this moves us in a good direction. On the last piece, I do want to say, I know that the Hospital Association will clearly list patient financial assistance in their notice, but I think that is the tool that many Vermonters will benefit from who are experiencing this. I don't think we should write anything in here, but I'm struggling with how to inject my office's support for this very tough question. Boy, we are telling people to go here for this type of care, go there for that type of care. And guess what? Most Vermonters just want to get care.
Mm-hmm.
And they're not thinking on that level of what kind of coverage they have or what type of hospital they're at. They just want to get care. So it's really tricky to think of broad communications, but how do we help people maneuver through with their scheduling something? And it's pretty rare that someone calls my office and says, I'm trying to get this type of care. What are the legal dynamics of leading me to go to one place or another? How do I avoid a big bill? But it does happen. Having pushed to have a moment in the seat, yes.
With the bill in its current form as revised last night, what can regular Vermont residents, people you represent, be most excited about if this goes into law?
Well, I do want to recognize that we've sliced this thing in different ways because we're now doing these two markets, the qualified health plans and the teachers at PPS hospitals. I just want to recognize that there are some Vermonters that are going to experience some real savings, and there are some Vermonters that won't experience anything. And I guess I'll go back to one of the central messages from yesterday, that focusing this legislative activity on 2027. That's sort of the task in front of us in this bill. And really very much, I know there's some language here that's now permissive about 28 and 29. But really, I want to get to a place where the board has gone through rulemaking and we are going down our path of system-wide reference-based pricing that affects all Vermonters. That is a real value to me. Yeah. So there will be real savings. I think there will be real reductions in the QHP and for taxpayers paying for the cost of teachers, educators' healthcare.
Yeah, you had said something like a minute ago, like that there were people who would directly benefit and then there were others who weren't. But I was going to actually ask about the indirect benefit to from all Vermonters of including the public workers, because even renters may benefit if their landlords aren't raising their rent as much because their taxes stabilized. So I do think that this bill is an important part of our efforts to control the cost of both healthcare and education.
Yeah.
So I mean, I think the way we're doing it is respectful and measured.
So can I? Thank you.
But I'm curious. But you, I don't know if you have anything else.
Right. So this is maybe gonna get me in some trouble, but this has a little bit to do with my knowledge base of how it works. I can see in the QHP how this will iron right through to rates, and I will be at the table and watch the board do it. I don't have it worked out in my head so clearly how the reduced costs for teachers' healthcare works itself so directly out into reduced taxes. And
Why?
Did
you not? Because I don't know that process. So I mean, I don't.
Maybe this is a question another witness can answer, but so I'll say it is certainly my hope that there's a dollar amount that shows up at the end of this that once we work through and that we can see that result in reduced tax burden.
Did anyone else?
I have a question.
Oh, go ahead, Val.
Hi, everyone. Thank you. I don't know how to raise my hand. I'm sorry. I
That's
can
right.
raise it at home,
I
but you're
can't
not going
see
to
it.
see me. Yeah.
I can't see it anyway, so.
So, I don't know. I've just been studying this quite a bit. I still don't really know how to absorb all of this. I do have a question. I'm concerned about every Vermonter being positively affected by this. For example, me and my husband, self-insured. I kind of want to know more about the subsidies and the waiver, whether or not we just say as a self-employed family or business, if we are not reaping the benefits of this bill, or if all Vermonters are not, how does that affect how does that affect the waiver, the subsidies in the future? Like, I don't know. I'm having trouble with this. Do we get money from what is it? 1332 only
Yeah. You're
if
talking about
everyone,
premium tax credits.
yeah.
Yeah. So thanks for the question. I think it reminds me a little bit that I went into the nuance of this bill, and this is a moment for sort of broader reflection. I know this is just a step in the path, but the overall path is a significant effort to right price our system in a way that we can afford to maintain it. And so it is, well, it is, I think, the most important effort that is going on in the legislature right now. This bill coupled with previous action. So I do think that it will help families like Val's. And I think I think families that are on the exchange, which I think pretty much all self-employed people would be, will see the results of this very quickly. Though I think I heard the sort of relationship to the premium tax credit question. I do recognize that for the significant number, I think it's been estimated something like 77% of the individuals in the exchange are getting a premium tax credit. And that for them, all other things being equal, they won't see this savings, or they won't see as much.
And that's because they're expiring?
No. Because the way the tax credit works, it sets a maximum amount that your family has to pay.
I know what you mean now.
Income and your size. And so a reduction in the overall cost just reduces the amount that the federal government.
Right, so it's like, because I get that, whatever that is, and whatever you just call this, a tax credit. It's not a subsidy, it's a tax credit.
Yeah.
So like, I get it, because it's like, if I'm paying 33 cents a month now, then that's not gonna go up. Because that's the max already.
So, and there's been a healthy debate, I think, between me and many people and others about sort of, where's the right place to inject these savings. And I have recognized that dynamic we're talking about. And then I also fully recognize the now 20-some% of Vermonters, 5,000 of which many of them are in the group that just left health insurance this year, who are incredibly exposed and harmed by the loss of the enhanced tax credits. And so bringing these prices into a reasonable range is a key part of attempting to secure this market, particularly for those people who are above the tax credits.
Go ahead, Brian.
I don't remember if there was testimony showing any projections, but do you have any idea what the numbers might be for people, like, in other words, all tax credits aside, what would you call it? Like not like the raw fee, but like the
total premium costs?
Yes, the premium cost without any embellishments or help, whatever. So like it's like 800 and something now, I think, for an MVP bronze. That's the cheapest one or something.
I'm aware that the chair carries the menu. That's right.
Okay.
Placemat.
So that, so
Brian, would you like to know?
well, what I would like to know is, look, let's choose just for the experiment.
Okay.
The second most expensive MVP bronze for an individual.
Second, also, if you really had to.
It's on the right-hand side. It's on the right-hand side because I know, because that's my section. That's my section of the
So these are
chart.
the special plans.
Oh, no, maybe that's not it. MVP at bronze was on the right, but they keep adding things.
Okay, well, there is a
Yeah.
MVP bronze.
It's expensive, right? It's
For an
like,
individual.
is it 4 digits yet? I'm not sure.
824,
See, I was close.
14 is the bronze 5, 862 is the bronze 1. And that's an individual,
Okay,
not a family.
that's what I was aiming
It's an
for, just to
individual.
start.
But
Yeah.
hold on,
Okay.
a $7,250 deductible
Wait, that's it?
for an individual.
Thought it was 15,000.
But that's for.
Maybe that's the one I have.
That's the other one.
Yeah, that's
That's the other one.
That's the cheapest plan, like,
No, there is the, anyways,
yeah.
you get there are ones over here, which are the health HSA ones.
It's getting more and more complicated, but that being said, let's use the $862 a month one.
Right.
Like, what might be the savings on that? For reference, do we have any idea? Are we just taking a guess, or is it gonna be like 100 less a month, 200? Are we talking like 400 less a month?
I think it may be that Blue Cross will be prepared to give an estimate of the percent reduction that this represents. I'm not sure whether,
You don't have that, it's okay.
given the way that we've spliced things a little bit differently for different hospitals, I'm not sure whether we have that.
And it's also very possible that it wouldn't reduce it at all, but what it would do is instead of going up 10%,
That's right.
it goes
Stabilize.
up 12%.
I think this is bigger than that.
Yeah,
I think in previous versions of this, when it was all hospitals, and let's remember that the cause, while there's lots of them, are not a lot of the healthcare dollar. I think we were talking in the range of 15%. Now I'm just getting myself in trouble because I had no confirmation. I think that this may well be a significant reduction in premiums.
Did you have a question? Oh, okay. Sometimes,
Scratch my nose.
yeah, sometimes you.
Well, I'm a deep thinker.
So I guess my one question is, so you started your testimony by essentially saying that this is not perfect. I acknowledge this is not perfect. As I just wanted to get your thoughts as somebody who was in the stakeholder group coming to this version. Do you feel as though this version strikes the right balance?
I think this version strikes a good balance. I think there was a good stakeholder group process. We didn't all leave happy for sure, but good communication. And I do want to say this is about this one and about the bill that Representative DeMar delivered so well today. Not easy to do a good stakeholder process at this time of year. Not easy. In the middle of the session when there's lots of time. So there's been some good process.
Thank you. Thank you.
Okay.
Yeah. Oh,
What is the timeline on this for, like when VSBA gets in on this? And did you discuss any of that? Like, I'm just wondering of a timeline.
reference-based pricing, which we did last year,
Yes,
is begin implementation in 2027, which essentially this is sort of that beginning because they're still in the rulemaking and so they can't implement actual things for 27.
yeah,
So they will begin 28.
Yeah.
And 20 and beyond.
so that'll be the QHP.
That will be
VI.
everything. Every
2028 will be everything.
2028 and 29, and there is no end date to reference-based pricing. Everybody thinks that, oh, we're gonna get to the reference-based pricing is not something that will ever end. Well, until another legislature comes in and strikes that. So it's primary healthcare.
Until the robots take over.
But that affects the whole market. Wait.
Something that I wanted to say.
Yes.
We find ourselves in this place with the need to define reference-based pricing for 27. That's how this bill started to be. But one lesson from this year on this bill for me is how much we set up a professional entity to do this work, and it's, I think, really important that they be allowed to run with it as much as possible without constraint. What happens at this table, no offense, is sometimes influenced by other forces. And I think in order to really be successful in this, I am really hopeful that we don't have to come back year after year to this table to be looking for exactly how to frame it. I'm hopeful that we can let it run under the direction of the board.
The rulemaking, I'm just trying to get my head around this. The rulemaking is Green Mountain Care Board. That has started?
Yes.
Okay, is there a
In
time?
the rulemaking process.
Okay,
I'm not sure.
Green Mountain Board, Diane Lanford, they are in the rulemaking process, but this interim step here, because it's not finished, it'll be a while. And this body and building, it tasked the Green Mountain Care Board last year to begin in 2027. There's a beginning point, but there will be many, many years to come. The other thing is important to take into consideration is that as reference-based price rolls out, if I can say it, one way or the other. You know, it needs to also be in step with our mission of, you know, making sure that the hospitals, the ratepayers, that all of this is not an overburden in any one direction. So as much as we would love, and sometimes the Senate yelled at us to get it done yesterday, there is consideration to other entities and how this will affect them as we go.
Thank you. I have.
Yeah, that, my question's for Devin.
Devin, do you wanna? I know you weren't prepared, but I would like to get your thoughts.
Thanks for having me. Devin Green, Vermont Association of Hospitals and Health Systems. And I am also thankful for the stakeholder process. I think I really appreciate all the parties coming together and working further on this bill. Mike Fisher's right. There was not total agreement on the bill. And so, but I do think it is going in a better direction right now. I'll just first say for the reference-based pricing piece, I think what hospitals are looking for are clarity and predictability and a long-term goal. And we appreciate you adopting Mike Fisher's long-term goal. I think that will be helpful in giving us direction. We've really been looking for direction this year. The 3.5% process, you wish that it could just say $50. That's what, or $50. $50 million, which is what we said all along. It's a defined number. We know what it's going to be. We can plan. We don't have a lot of time to plan at this point. We can just take that and run with it instead of spending time trying to figure out where that number might land. So we would argue for $50 million. And we realize that, I don't know if this makes much of a difference. We appreciate the years going forward, 28 and 29, being a may instead of a shall. We would like there to be flexibility there. And again, hope that this can be done just through the budget process. So there's one process and it's not multiple processes on top of each other, just for sort of planning purposes. So we would say $50 million, just leave it at that.
Where are we? I'm sorry.
I think on page, the
That
3.5%.
equals 50 million, okay.
Yes, 3.5%, I think is more. We don't actually, I don't totally know what the amount is, and that's why we're just saying.
I just want to ask the ledge councils, so we had discussed putting 50 million, but Jen had concerns about it not being like statutory instead of being session law.
Like I said, council, it just, I mean, we can do it however you want. I think it makes sense to codify some of this language because it's going on for a third of years. It feels odd to put a specific, very large dollar amount in statute.
But if it's just for FY 27,
Doesn't mean we can't do it. So I thought percentage was sort of more a percentage of a defined, you know, set amount or known quantity seemed more consistent with what we typically put in statute, but we can say $50 million if you want to say $50 million. That shouldn't be the reason you don't move forward with legislation people are supportive of.
I will say, I mean, that is a known quantity, what that number is, and we spent a great deal of time with calculators.
Yes.
And that gets us very, very, very close to that 50 million. That 3.5.
okay, we would like the final number. We would like to understand the final number so that we have agreement.
It's my direction.
And then, so that's where we are on the reference-based pricing piece. And then on the,
So that before you go on, if
Yes.
you want it now, or I can wait.
no, you can,
I am curious, and you may not know this off the top, but what percent of our system is PPS versus critical access?
So this would represent 4 hospitals.
Right. So what percent of our system is of?
Oh, in terms of like
Yeah.
money or?
Well, I know you gave me
People
more
or
of this. I'm just wondering,
services?
I mean, I'm trying to understand what not having a critical access hospital means financially and also for them.
I think that's like $3 million or something. I don't,
Yeah.
I'd have to go back. It's very small.
small.
So that's what's interesting too. So not having the critical access hospital seems to be reasonable in terms of this process. I just want to understand the impact. I'm looking at impact.
I think it is reasonable, especially because I think it's easier operationally because with PPS hospitals, there are prices that you can look at and convert with critical access hospitals because they get reimbursed on a cost-based reimbursement. That is harder to translate into direct percentage of Medicare prices, that sort of thing. And so it makes sense to start here and keep the PPS or keep the critical access hospitals out for now.
Do we know how much it would come from the PPS? If you said 3 million from the critical access, what's the PPS?
I don't know. I'm not totally sure about the 3.5% inclusive of the budget, I think is something like 56, 50.
That's where that number came.
56. Okay, is that the total? Okay.
Oh, but because we'll have Emily speak.
Okay.
She just popped up.
Oh, great, perfect. And then, yes, so that's the.
So major orders of magnitude.
Yes.
Across the system, and that's what I'm just trying to understand.
Yeah.
The rest of it?
I'll hit the critical access hospital cost sharing piece, the most hated policy.
Read the thing that you received, so thank you for, that's very helpful.
Yeah.
That was really important, I think, for.
Yeah, yeah. And so I think our concern in this section is there are things that hospitals can do voluntarily, but they make it very clear that it needs to be voluntary. And the intent can't be to reduce the cost sharing. And so I don't know what to do here because the intent language is already in previous drafts. Like there's been legislative history around it, but just like going forward, when hospitals are adjusting charges, I don't know.
So you really just have a problem with the intent?
I don't even know if I have a problem with it. I just think it sets things up for when we, like if we have the intent and we report our over 5-time prices and then those all come down, are the feds going to look askance at that? That's the issue I'm grappling with. I don't know how to solve it.
Although I still cannot wrap my head around. I understand that the feds say you can't do it, but reducing it to 5 times doesn't affect the Medicare payment at all.
They get the extra.
Well, they get the extra money.
It's not really about.
It's not about the payment, it's about what we're paying them for
Yeah.
their back policy.
They're not gonna hear about the little trivial stuff. that we're doing.
So, I mean,
We could take
we
out the
don't
intent.
really need the
Yeah,
intent.
that's where I'm going. Take it out.
We could just have, on or before the state, you should identify all your services.
Who
Get rid of the
suggested it?
intent?
Who suggested the
What-
intent? Yeah, I'm trying to remember.
Oh,
14
I think,
of 13, it starts on.
I think this committee,
It was just setting the table.
yeah.
But was it that like you requested Ledge Council to write it based on our discussion? Is that how it ended up in there? Like no stakeholder told us to put it in, right?
No, I think that I think that there was language in the Senate version and then that it started. So this whole Green Mountain Care Board and the General Assembly have recently become aware. So that all came from the Senate and then they said, don't look at it. Wasn't that in the original version?
They had the work group in there.
Okay, well, maybe in the very, very short time I can work with Ledge Council to at least maybe we know what the intent is, but maybe we shouldn't have it in there. So,
Yeah,
But we'd still get the data.
yeah,
We keep the rest of it.
yes. Keep the rest of it. We just wouldn't have it's the intent to provide some relief to Vermont's and other Medicare and the consequences of the federal requirement. We probably shouldn't. I totally get that.
And I mean, and you can talk to Ledge Council about it. The fact that it's in the legislative record could potentially be a problem too, but
but we decided not to put it.
yeah, and I don't know how that would play out, but the other piece is, and we haven't talked to the Green Mountain Care Board about it yet since the CMS memo, but we would still want to make sure that everything complies with federal law going forward. I'm sure they will do that, but we would like assurances that this is not going to be dealt with in our hospital budgets.
Hear you.
Thank you.
But the hospitals are aware and they can think about it on their own.
Yes, and there are things that they can do on their own around payment policies and notification. And we're still in touch with the delegation. And if all of you want to get in touch with the congressional delegation, and if you get complaints about this, tell those folks to get in touch with the congressional delegation too. I think that would be helpful.
Okay.
Thank you.
Some suggestions in here about what we could do to help seniors though, like, and I'm looking at that memo that
Yeah.
I'm wondering about some of those. I mean, could we, so about that?
We are drafting a notification. And in what we have so far, what we're saying is we have financial assistance policies. Here's who to call. You can go to this website to find out more information about the Medicare Savings Program and your eligibility for that. But we're happy to add.
Yeah, there's a
Whatever
4 and 5
resources.
Medicare supplemental insurance,
Yep.
covering, so ensuring robust Medigap enrollment, so somehow involve getting, I don't know what steps that would require and where it would, that's 4 and 5 in the memo. State Medicaid and low income assistance program, so I don't know what action might be taken, it might not be today, but I mean, clearly, but I wouldn't want to let that go if that's an opportunity for seniors.
We're happy to continue working on it to the best that we can, and it may take a state partnership in terms of helping seniors out.
Yeah.
No, I'm just twitching because I'm in pain.
Oh.
No.
That's like Dave. Dave raises his hand by going like this, and then so every time I see his finger go up, I think he's
I
raising.
do have a big hand.
He has a question.
I have a question. I just have a reminder that time is short.
I know.
And just one more thing, sorry, on the 56 million, the percentage, I think that is 56 million, but with the critical access hospitals in there, I think it's more like 59 million total impact to the system. So I just wanted to point that out. Okay, thank you.
Thank you. Emily, thanks for jumping on. So it is my intent, just to let you know, it's my intent to work with Jen for a few minutes over the lunch. And then we will vote on this at 1 o'clock when we come back here, okay? Sorry, Emily, go ahead.
Thank you. Apologies for not being there in person. Emily Brown, Executive Director at the Green Mountain Care Board. So I was listening to the prior testimony from Vaz about concerns about the percentage somehow being not definitive or not identifiable. So the language, as I read in the latest draft, has the 3.5% based on the approved fiscal year 2026 hospital budgets. So those are approved defined budgets. Those happened last summer. The Green Mountain Care Board has done a calculation excluding Brattleboro, which I think is a rural community hospital demonstration program. So they're not going to be included in this rate reduction. And so the calculation that we have done without Brattleboro is $54.6 million. So the Green Mountain Care Board is able to define that number and, has the approved budgets with which the 3.5 is based on. So we have full confidence that we will be able to do this calculation if this is the version that passes through House Healthcare. And I just wanted to comment also on the CAW, the CMS memo related to the CAW cost sharing issue. I think one provision that stuck out to me was that there's an expectation that charges that are in use in the Medicare program, their reasonable relationship to the cost of furnishing services. I think what we have discovered through this consumer complaint is that many of the costs at the CAWs do not have an obvious relation to the cost of providing those services. So while I agree that this memo does raise some concerns about if it's the intent to lower charge master amounts to somehow, induce Medicare to pay more, I understand that. But I also think there's an opportunity here for the CAWs to look at their charges to make sure and ensure that they are reasonable in relation to the cost of them providing those services to Vermonters. So I think even without, providing the intent to address the Medicare issue in the federal law, there is an opportunity here, I think, for CAWs to do some type of analysis to make sure that what their charges are rational or reasonable in relation to the costs. So I just wanted to offer that comment after reviewing the memo.
Yeah, I appreciate that comment. The requirement is that we not artificially change our to affect Medicare, but there's another component, and that is that charges need to be reasonably priced. And so, both sides are.
What it says is bear a reasonable relationship to the cost of furnishing services.
So I think having the CAWs actually look at their prices is really important. Any other thoughts?
No, that's it. And I just want to also echo what Devin and Mike and others said about the stakeholder process. This has been really challenging, but I do appreciate everyone's ability to get together and discuss these really tough issues. So also wanted to echo that. Thanks.
And I appreciate all your work on this as well. Thank you. All right. Oh, yeah, I'm gonna have Blue Cross, if you want to just give a final thought on this version.
Yeah, I think just wanted to, Courtney Harness, Blue Cross and Blue Shield of Vermont, just wanted to talk to Rep. China's question about the premium and expectation there. And so the VHI plan is kind of its own beast, as we've seen, and our biggest client. But for the entire qualified health plan, we think a number like what we've heard, 55 million, is around 10%, which is a big deal. And so if that number is $880 a month on premium, and it maybe doesn't go down to 800, how it will work, and you'll see our rate filing on Tuesday morning. If MVP and Blue Cross file a 10% increase, this would effectively make that zero. So I think that's a benefit.
Are you giving us a preview?
No. You almost had me. And, I would say too, just a question about the critical access hospital involvement. And so, I would say this is fantastic premium and cost relief for the entire qualified health plan. I would just first say, from Canada to Massachusetts, east of Barrie, there's not a PPS hospital. So folks in the qualified health plan will experience a premium reduction here, but the price at their hospital doesn't materially change. So I think my question is more around, probably for the care board, after we're done here. The premium is good. We've had some deductible conversation as well. If people are paying out of pocket, then do we suggest that they drive from St. Johnsbury to Barrie for their service, because Barrie is operating reference-based pricing? Or do we suggest that they stay at their critical access hospital to keep their care local? It's not our decision to make for them, but the where, when, and how much are the things that we grapple with. So I don't require an answer. I'm just putting the question out.
I think that it is a great reminder of the lack of, even though we have price transparency, the actual real lack of transparency in the entire healthcare system in price. Because we also have Blue Cross saying, don't use UVM.
Right.
I mean, publicly saying that, and then steering to critical access hospitals where people may be now using, if they're a Medicare beneficiary. And I mean, we're just telling people to go all over the place.
Agreed.
And shop around, which is not what we want in our healthcare system. Emily, did you have something you wanted to point out?
Yeah, I actually agree with Courtney's comment in that by limiting this just to PPS hospitals, we are not providing this relief to a lot of our rural citizens who access care at critical access hospitals. They will see, as was mentioned, a premium reduction, but they're not going to see a reduction in their cost share when they access those services at a critical access hospital. And I think the Green Mountain Care Board had supported implementing and spreading this relief across all hospitals. And I believe that's what the Senate version. So just wanted to, I think it was a good comment and wanted to echo our support of including this across all hospitals and not just PPS.
I hear you.
I'd like to echo that
Of
too.
course, if we could get the cost of premiums under control, then people would be able to select plans that don't have $10,000 deductibles on them, and maybe that would. Thank you.
Yeah.
Thank you,
thanks.
Courtney. All right, so let's, we gotta come back to this at 1 o'clock. And I'm sorry, unless there's any discussion, does anyone wanna?
Are you
Just-
gonna make the change to 50 million or are you keeping it at 3.5%?
I don't think it's wise because of Jen's clunkiness of it. And I did change, I will say that this concern was brought after stakeholder engagement. And I did, I changed shall to may. Disappointed.
Just saying, I hear this.
As our healthcare advocate pointed out, is this perfect? No, it's not perfect. The thought that the calculation, let's just be clear. Green Mountain Care Board doesn't need any of these words on the page to do anything at all. But what they do need these words on page 4 is they need the words to be able to target the savings to these two markets. Without this bill, they would do whatever they do, and it would be spread across the entire system of care, which if it's spread out to the entire system of care, no one actually sees a significant reduction of anything. So that's why. And I did change shall to may. I will work with Budget Council around the intent language in the new section 10, and change some of that.
So help me understand if it's May and no one engages with it, what happens?
Well, particularly with two, the B2.
Page.
I think I got, it's page 6.
line 11.
Line,
11 is the shall may.
oh, I'm not looking at the right version.
Madam Chair, can I clarify my premium comment?
Yes. Go ahead.
50 million would be, sorry, Courtney Harris, Blue Cross Blue Shield, 50 million would be 10% of our premium. So if it was savings of 50 million to us, we're only half of it.
Yes,
market.
you're only.
So, yeah, so we would look at about 5-ish maybe.
Yeah.
Rough, very rough.
You said that, and I'm like, you're not
Yeah.
the whole market.
Sorry.
So no, it's not as though all 50 million would be targeted to Blue Cross, although the majority of it would be because of VHI. But MVP is in there as well.
Thank
So can we, but probably be about 75% of that savings. So on page number 6. Lines 19, 20, 21, and then onto the next page. I think the May is particularly important there because if after 1 year it proves to be really chaotic, they can come back to us and or choose not to move forward with that.
Can we define chaotic?
Well, I was looking at the May, I spent 2 years trying to define the word transformation. If you want to come up with a definition for chaotic, I'm happy to do that. I think that this bill was a very great stakeholder process that got as close as we could possibly get in the time that we have on this bill.
Oh, wait. Committee
Can I
comment.
make a comment?
Oh, of course, Val, go ahead.
Hi, thanks. So we're gonna vote on this later.
At 1 o'clock.
I want to say thank you for all the work that everyone has done. I cannot, this bill scares me. It just does. And I'm not going to pretend I understand it completely. I would need more time with a new version to go through it and have conversations with people, like my hospital in Rutland, or I can't vote on this right now. I'm sorry, I need more time, and I know we don't have time, but for me, that's not a reason to say yes. And I really apologize for that, but
I completely understand, and I know it is rushed, and unfortunately, this is what end of session is. And, you know, sometimes we do things in the end of session and get them through, and then we come back to them next year. Okay. Any other comments? But we will be voting on it at 1 o'clock. I don't have a choice in that.
We have room to comment at 1 o'clock.
Sure,
Okay.
sure.
Do you want to comment now?
No.
I was just saying, at 1 o'clock, we have to move to 197. And so let me set the table for you here. 197 is pretty much exactly how it was when we got it. And there has been, there are like some, it's not, I wouldn't even call it markup. There are some ideas that are sort of in it. But my intention is this afternoon, we as a committee are going to go through this bill and do true markup, which is we are going to create what the end result is going to be all together. So
Be prepared.
be prepared. So